So I'll try to keep this as concise as possible.
Menu and start.
Okay. All right, so my name is Josh. I'm a med student at Rush out in Chicago, and this is my title here. So we studied whether or not autografts or allografts were better for predicting return to sport rates following a revision ACL reconstruction surgery. This was pretty funny because my presentation's about knees. So I'm just going to throw some numbers at you as well. In the US, there are about 200,000 primary ACL reconstructions that are performed per year. This has increased in the past few years and understandably has led to an increase in the number of revision ACL reconstructions performed as well. It makes sense because the primary reconstruction surgery is pretty good, it's just not perfect yet. The success rate's anywhere from about 75 to 97%, so just because there's that area for failure, there's an increase in the rate of revisions that are performed. So when is this actually indicated? So obviously I just mentioned that you do a revision after a primary would fail, but the question is why would a primary reconstruction fail in the first place? Some examples are when patients experience complications following a primary ACL, such as recurrent instability due to like a graft failure or some sort of other complication that a patient would experience post-surgically. Also surgical technique failures. These are really rare. They don't happen very often, which is why they're not really reported in the literature. But it does happen once in a blue moon, so it's important to keep note of. Revisions also indicated when athletes experience graft failure following a primary reconstruction and want to return to their sports that involve actions like pivoting and cutting, which are things that put tension and stress on the ACL. We do know, both from primary reconstructions and also revisions as well, that just generally the type of graft that we use can predict post-surgical outcomes for these people who undergo revisions. There haven't been a lot of work done in the area of seeing how quickly a graft choice can help an athlete return to sport after they have a revision. So this was a little bit of a tedious process for me and Dr. Sherman, who I worked with this summer in the sports group, trying to investigate that. I think like Steph mentioned earlier, we do have different types of grafts we can use here for these processes. We can use autografts, usually in the setting of a primary ACL or even revision. It's common to use a hamstring or a bone patella tendon bone or a BPTB. Allografts don't have as sort of clear cut as a rule. It's really more up to the surgical team and the surgeon to figure out what they want to use if the allograft is used at all. But the trend really is towards autografts, which I'll talk about a little bit later on. To sort of piggyback off of that, we do know that autografts are generally superior to allografts in terms of both primary and revisions. This is just a general slide talking about a lot of the research that we found showing that autografts themselves have really good success in terms of predicting return to sport rates following a revision. A few of these are from the past few years, so 2016 and on. A couple are from early 2000s, even in the 90s. So there have been a pretty wide range of studies that have been put out over the past few decades. But generally for autografts, they show pretty good success, higher than 70% return to sport rates in athletes really of all ages and all levels of skill, which is pretty promising. This column to the right here is the IKDC score, which is the International Knee Documentation Committee score. It's more of a stability score that are included just to see how well one of these grafts are going to hold up and just to track patient outcomes over time post-surgery. And sort of going on the same point, but sort of the opposite side of the coin, allografts we know to be inferior in context of both primary and revision ACL reconstruction. There aren't a lot of studies that are out there that talk about return to sport rates following allograft use just because we know that they're inferior to autografts. But sort of the rationale why these allografts are inferior is sort of listed up here. Again, there's a wide range of these studies of when they're from the 90s up until now. Just some of the failures and the shortcomings you can see with allograft use include increased risk of rupture, a lower rate of re-revisions when you use autografts. We know allografts have a lower degree of incorporation into the body than autografts do. So pretty much all of these taken together point us in the direction of wanting to use an autograft in the context of a revision ACL. What's interesting though is that there's not a lot of work that's been done directly comparing autograft and allograft impact on return to sport rates following revision ACL in the same study itself. So this was definitely challenging. We searched pretty much every database we can get our hands on, including the MARS group, which is one of the biggest ACL reconstruction and revision ACL reconstruction databases that we can find. That's this Retinol publication up here. And once again, all these studies here that talk about comparing autos and allos in the same study do show a preference for autografts in terms of predicting the highest return to sport rates following revision, and that makes sense given all the information that we know. The interesting thing was that every other study that we found that directly compared autos and allos in the same study showed pretty much the same findings that we saw during primary reconstruction, and also just sort of general outcomes with revision ACL and other categories that we can track to follow patients after they leave the operating room. So just to wrap up a little bit, this is the only literature review that actually directly summarized autograft and allograft use on return to sport rates in the literature that we could find anyway, following a revision ACL, so that was pretty cool. Even though there are a few studies that directly compare the effect of autografts and allograft use following revision ACL on return to sport rates, they all pretty much show the same thing. That's a preference for autograft use for a lot of those reasons that I just talked about over the past few slides. So given what we know, we do believe that there's a preference and sort of a superiority to use autografts following a revision to help people get back to their level of sports as quickly and safely as possible, but just because there are so few studies in that realm of directly comparing the two, there does need to be more research done. It's difficult because a lot of these retrospective studies, you can't really try and do a randomized clinical giving people a graph that you know is inferior just for the sake of adding body and adding volume to a literature base. So that's really the only main obstacle you run into here, but given what we know, this is definitely the direction that revisions are going to go in the future. Yeah, that's all I have. Thanks, guys.
The points are well taken, but many times, I do a lot of revision ACLs, you don't have the opportunity or the option to use an autograft, right? Either they use the patient's patellar tendon the first time, and it's actually very difficult to do. You can't really do we can, but it becomes a tunnel size issue. It's very hard to do a hamstring autograft after a failed BTB. You can go the other way. If someone's failed a hamstring, it's a home run to use their patellar tendon. Mm-hmm. We end up using allograft many times because that's our only choice.
Okay.
So it brings up two questions. One, if it was you, would you consider, you failed on your right side, would you consider using your left patellar tendon for your right side? Would you go after a normal knee joint to get what you'd consider an ideal graft? That's my first question. And two, or the second one's kind of a comment. When you write this up, I hope you write this up.
Yeah.
You have to be careful when you include some of these studies from like the 90s and 2000s to more recent, because the techniques have changed, right? So back in the 90s, they were doing more of a what kind of ACL reconstruction? Transtibial, which is vertical, and now more recently we think we're more anatomic by doing what's called an independent drilling technique. They're two different animals, right? So I think you just gotta have to maybe even subclassify or substratify, based on the time of whatever study you're utilizing to see how they're doing their actual ACL. Mm-hmm. So my first question, if you have failed on the right side, are you gonna let me take your left patellar tendon because it's an autograft, or are you just gonna get one out of the freezer?
It obviously depends on, the patient's characteristics, how old they are, but that would
make
more sense. If it were me, I'd probably just go for the allo, because I don't want to compromise my stability.
Absolutely. Absolutely. So it's good to know, all this information is really important to know, but at the same time, we're sometimes just handcuffed in what we can use.
Right.
Marsh? Oh, Steph?
First of all, great job. Did you notice in all the research you did that there was any sort of change? So while you showed that most of them prefer autographs, did you notice as patients got older, was there a shift at all, or was it non-age dependent?
A shift, you mean in terms of graft that's used?
Yes, or graft that's preferred.
I think, like what Dr. Strauss was saying, it's really just a matter of the patient's own characteristics. Yeah, we definitely know that at any age group, in terms of any athlete age, and in terms of just predicting a return to sport rate, or just overall sort of outcomes of the surgery, autographs are definitely favored. But if the situation sort of presents you with something difficult, like we talked about, like sometimes you're handcuffed and don't really have that ideal sort of path to go down. So that's a really good question. I honestly don't know the answer. You probably have to go back into the literature to look more specifically.
So there is an aging influence. So most of the big databases, like the meta-analyses, show that pretty much over the age of 35, there's absolutely no difference in outcomes or failure rates in autograft versus allograft. So, quote unquote older people, but not at 35 consider old, I think makes you feel terrible. A lot of times they'll go with an allograft because it's easier recovery. But for anyone under the age of 29, an allograft is really the wrong choice if you have an autograft option. Is that fair?